Hello and welcome to the Completed Life Initiative's Town Hall event, A Good Death, International Perspectives on Euthanasia. This Town Hall discussion will feature an important clarifying conversation on key definitions and affiliate terms relating to voluntary assisted dying, or VAD. Our esteemed speakers will present an overview of international perspectives and misnomers that persist regarding VAD, and will examine the term euthanasia, which carries a historically negative connotation but is legal in Colombia. The term euthanasia derives from the Greek eu and thanatos to mean a good death. While often mistaken to be the same as euthanasia, medical aid in dying, or MAID, holds a more neutral connotation, yet remains greatly debated and often misunderstood. Within the United States, MAID requires the patient to self-administer the medication. By contrast, in Canada, MAID allows for the physician to administer the medication. Both countries' terms refer exclusively to an eligible person choosing a voluntary assisted death, but by different means. Importantly, this distinction pertains to a central tenet. A chosen death must always be voluntary, and must be entirely motivated by an individual seeking the time and circumstances of their death once they have reached a point where they view their life as complete. Now, let's meet our speakers for today's event. Jane Lowers, PhD, MPA, is an assistant professor in the Division of Palliative Medicine at Emory University in Atlanta, Georgia. She holds a bachelor's in journalism from Northwestern University, a master's in public administration from Baruch College in New York, and a PhD in palliative care from Lancaster University in England. Her work focuses on the differences between the care people want at the end of their lives, the care they receive, and the factors that shape their choices. This has included a study on caregivers of people who chose to voluntarily stop eating and drinking to hasten death, or VSED. Current research on people aging without close family, and work with the Hastings Center on a project titled Dementia and the Ethics of Choosing When to Die. Lucas Correa Montoya, JD, is a lawyer, consultant, public servant, academic, and human rights activist. He is also the director and strategic litigation leader of Desk Lab, an innovative and visionary firm that is committed to putting rights into action, creating strategies, mobilizing ideas, and providing services to generate profound changes in our society. In his professional career, he has served as an advocacy leader for the Saldariaga Concha Foundation, a Colombian organization that works for the social inclusion of older people and people with disabilities. He was recently a consultant to the Inter-American Development Bank, IDB, on issues of disability, legal capacity, and regulatory design. He served as Technical Deputy Director of Old Age and Aging for the Secretary of Social Integration in the city of Bogota, Colombia. Our moderator for today's event is Sarah Kiskaden-Bechtel. Sarah Kiskaden-Bechtel, MBE, is the inaugural Program Director of the Completed Life Initiative, who brings with her 13 years of experience in bioethics. She is an innovative and strategic problem solver who has devoted her career to untangling oft misunderstood and oft stigmatized issues at the heart of human experience. Her expertise ranges from researching the impact of cultural traditions on the spread of HIV/AIDS in Swaziland, to facilitating a CDC award-winning clinical research study in tuberculosis control at New York City public health clinics. In addition to directing the Completed Life Initiative, Sarah teaches as associate faculty in the Masters of Bioethics program at Columbia University. She serves as a member of the Carson Tahoe Health Institutional Review Board, is editor-in-chief emeritus of Voices in Bioethics, an online journal, and is a member of the Empire State Bioethics Consortium. We thank you all for joining us for what is sure to be an insightful town hall event. We encourage you to input your questions and comments into the chat feature located at the bottom right corner of your WebEx window. After the first hour, we will turn to Q&A with our speakers. If you have to leave early, don't worry, a recording of this town hall will be available on our website and YouTube channel. Now, without further ado, we welcome to the stage Jane Lowers, Lucas Correa Montoya, and Sarah Kiskaden-Bechtel.
Hello and welcome. A warm welcome to our esteemed panelists, Jane and Lucas, and thank you so much for joining us today. And to all of you in the audience, thank you for being here. A little roadmap of today's event. To prime our conversation today, we begin with a presentation from Jane, followed by a presentation from Lucas. From there, we will dive into a moderated discussion that will elaborate on the ideas raised both by Jane and Lucas. And at the top of the hour, we will start to incorporate your questions in the chat box. All right, let's begin. Jane Lowers, over to you.
Thank you so much, Sarah. It is very exciting to be here. We're going to talk a little bit just about some ideas around language and culture and what different words mean in different contexts. So I'm going to try to introduce a lot of ideas, and then we'll get to see how some of them have played out specifically in Colombia from Lucas's perspective, that we can take it from there. So one of the most important things to realize is that there are no neutral terms around the idea of choosing deliberately to end one's life. And depending on where one is situated and what one's intentions are, those words can vary quite a bit. And so the words that are up on screen are some of the different ones that we might hear depending on who's talking and about what. So I thought it would be interesting to kind of break down a little bit what might be behind some of those choices, because these could mean the same thing or really not. So one of the first things to consider, and this was alluded to in the introduction, is where's this discussion taking place? And in the US, we have tended to go with terms like physician-aided dying or physician-aided death. And as mentioned, in Canada, the phrasing is medical aid in dying. And one thing that's important there is that choice was deliberate when Canada legalized the practice some years ago. And part of the reason is that in some of the northern provinces in Canada, a physician isn't always available. The local health provider might be a nurse practitioner. So they chose medical as a more inclusive term to encompass that there could be a range of qualified professionals. And in fact, unlike in the United States, in Canada, administering in dying is not limited to physicians. So there's always a story behind the terminology. Another interesting thing, and I didn't know this until Sarah pointed it out, and I think it was Peggy Batten, the philosopher, who brought it to her attention, is not surprisingly, German has a lot of words for everything, but they have 4 or 5 different words that translated back into English would come out as suicide, but in fact they mean quite different things. There's one term that would refer to sort of an accidental death. You were cleaning your gun and it went off. You died at your own hand, but that means something very different than a planned and intentional death. And the word that is actually most applicable to what Dignitas, the Swiss organization, uses is a German word that means something more like free death, and the connotations are a little more positive. But if you translate that to English, it comes out as suicide. So when we look at what's legal in Switzerland, we say assisted suicide, and that's different than probably any other country where it's considered legal. It's helpful to break down some of these nuances when we're having a conversation, particularly if we're having a conversation with people who may hold different views or different understandings about some of the things we're talking about here. So these are some questions that I think are actually more useful than choosing an individual term. The first is, who is the person who's initiating the intentional death? Who is the person who is interested in dying? Who's making the request? And we're assuming we're in a context where somebody needs to request that this thing will happen. We tend to be most comfortable when the person making the request is the person who is interested in dying. To varying degrees, different cultures, different legal systems are okay with somebody else making that request on the person's behalf. I was reading a little bit around today, and I think Belgium is the only place where assisted dying can be requested by advance directive. Otherwise, no, Netherlands, sorry. Otherwise, it has to always be sort of made in person, in real time, confirmed in real time by the person wishing to die. And so there's kind of a gradation here of where people might be comfortable with the concept of intentional death and where they might draw different lines. Another key issue is who is actually taking the actions that result in death. In the United States, the person who is interested in dying needs to be the one who is ingesting the lethal agent. And I believe in the United States that it must be taken orally. In other scenarios that isn't necessarily the case. Both self-ingestion and administration by a medical professional are legal in Canada, for example, and people generally much prefer that the medical professional be the person who is administering the agent. It reduces anxiety. People worry a lot about things going wrong in the moment of enacting aid in dying, and they feel more confident when a medical professional is involved. But in the United States, one of our kind of, I'll say safeguards, but that's not the right word, is to make sure that this is truly a voluntary act. It's truly being done by the person who wishes to die, and so they have to ingest it themselves. And we'll talk in a minute about how that can cause some other challenges. We also get very interested, and by we, I mean, as a culture and as a legal system, we get very interested in why somebody is interested in intentional death. In the US, as I think everybody is aware, someone has to be diagnosed with a life-limiting illness and essentially needs to be qualified for hospice to choose aid in dying in the states where it's legal. Other countries place the rule around persistent and unbearable suffering. That might be physical, that might be psychological, but it needs to be ongoing and unbearable in their estimation. The issue of choosing intentional death for life completion in the absence of those things is a more nuanced discussion. And then there are ways that we choose to think about what is the nature of death and how acceptable is death in a given culture. One of the ways that we distinguish suicide from a planned hastened death, where for people who make that distinction, is it social or is it secretive? Suicide tends to be secretive. There tends to be an understanding that other people would not approve and might try to stop you. Whereas a planned assisted death can be a more social occasion. And certainly there are plenty of ethnography and other stories to that sort of bear that out. Planned versus spontaneous. It's very planned. That makes the powers that be feel much more comfortable that this is permissible. And then, is it intentional and is it voluntary? And as the opening voiceover alluded to, voluntary is sort of at the key to this. So these are some of the nuances that we talk about that might actually be more relevant when getting into a discussion about what different terminologies mean, rather than using them as a shorthand. It could be helpful also to think about why are we interested in some of these issues? And for that, we need to look at what the broader culture values. Are we as a society more individualistic or more collectivist? Do we put more emphasis on the rights of the individual and their ability to make choices about what's best for their interests, or about the role of the state? And does the government have a say in who gets to die and when? There are also a lot of discussions to be had about what are the values that we place on life, on autonomy, on the right. Is suffering to be avoided? Is suffering valuable? Is suffering part of life? And along with that go a lot of discussions about how do we value aspects of life or people whose lives look different than our own. So do we value life less as people are older? Do we value life less when people are living with disability or illness? Do we value life less when we're talking about something like dementia, reduced cognitive capacity? And these issues, I think, are at the heart of why a term like euthanasia can be very scary and kind of a cultural bugaboo, because while it might mean a peaceful death in the original Greek sense, what it ends up calling to mind are things like the state deciding whose life is valuable or whose is not. There's another word that starts with EU, and that's eugenics, which is historically kind of closely related. There have been social movements in recent human history to decide what life is worth living, and for governments or empowered individuals to make that choice for others: who gets to bear children, who gets to live, whose genes should be passed on. It's one of the reasons that in any sort of conference or academic setting where discussion about the ethics of choosing whether and when to die come up, there's always a strong presence from the disability rights community. And one of their key concerns is what someone else might perceive as unbearable suffering might be an average Tuesday for them. If unbearable suffering means not being able to dress yourself or feed yourself or toilet yourself or living with ongoing pain, that might be your own definition of unbearable suffering, but it's what they live with every day. And there's a legitimate concern for historical reasons that if we decide that that is unbearable suffering and it merits allowing death, that there might be a slippery slope that would lead to people with disability having fewer rights, or maybe being encouraged to not suffer by choosing to die. That hasn't played out, to my knowledge, in any of the data that have been recorded about assisted dying in the United States over the past 20 years, but it's an ongoing discussion, and it's rooted in a lot of much more complicated social values. So I think that would probably be, wait, one more slide, we'll wrap it up. These are some issues that I'd like us to keep in mind when we look at the Colombian experience and how that country came to terms with changing the legal status of euthanasia. But as one last step, I want to throw out, I sit in the Division of Palliative Medicine, so I'd be remiss not to talk about what are some things that people might look at beyond choosing hasten death. And these tie back into some of those cultural values. A lot of times when people are interested in choosing hasten death, they're afraid. They're afraid of something uncontrollably bad that is coming down the pike. And any physician or medical professional who's going to be working with somebody on making that determination about whether that's the right choice for them is going to go through some of these other options, starting with adequate medication and other palliative measures to address pain and other symptoms. People might also have the option to stop life-sustaining treatments that they're on or not start them, maybe choose not to start dialysis, for example, something like that. That's not always an option. In some cases, people might look to palliative sedation if that is truly the only way to manage uncontrollable pain. People can also look at voluntarily stopping eating and drinking, or VSED, which, this is my favorite phrase ever, it's not illegal. There's nothing in the US law that says you cannot do it, and the most closely related laws suggest that you can, but it's not codified anywhere. And then all the way on through physician-aided death and voluntary active euthanasia. So there are a lot of different options that people might want to consider that might get the job done, other than active physician-aided death. I'm going to stop there, I think, and turn it over to Lucas, but I hope it will think about some of these issues as we talk about how these things play out in a real cultural context.
Thank you so much, Jane. And over to you, Lucas.
Okay, so thank you so much, Sarah and the Completed Life Initiative for this invitation. Thank you, Jane, for your presentation, and I will start with mine. So today I will be talking about the right to die with dignity, and I will share with you some details regarding the Colombian experience. For some strange reasons, our country, Colombia, which is a South American country, is one of the most advanced countries when it comes to the right to die and the right to die with dignity. I will be talking to you from a legal experience or from a legal perspective, a different perspective when we compare it to the medical one. So in Colombia, the right to die is an emerging human right, it's a new right. But it's not only a new right or a new possibility for the people here in the country, but it's a constitutional right. When it comes to the right to die, we are talking about a constitutional issue, something that is encompass our constitution, and it is compared to the right to live or the freedom of autonomy. So it's at the top of the discussion here in this country. But it's a right created by judges, not by Congress. We don't have a law regarding the right to die or regarding euthanasia or medical assisted suicide. We have somehow 14 decisions from the Colombian Constitutional Court that all of them have created the right and have given content to the right. With an emerging human right, a constitutional right, and a right created by judges, the right to die is a multidimensional right here in Colombia. So it's not a right to euthanasia, it's not a right to assisted suicide. It is a right that gives us, Colombians and foreigners that live here for a year, 4 different mechanisms to access a dignified death or to make decisions in the end of life. So the first mechanism is the access to palliative care. And I think this is something very innovative, outstanding, because palliative care is encompassed within the right to die. This is an idea that some of the palliative physicians, of those specialists, do not like, but the Colombian Constitutional Court has created this right and has said palliative care is included in the right to die. You can access a dignified death to palliative care, to any kind of medical provisions regarding suffering and the illness. So palliative care is included within this right. The second mechanism is what we call in Spanish, this is not a very good translation, the adequacy of therapeutic effort. So it's the possibility of refused treatment. And somehow it encompasses different provisions that resembles medical assistance in dying. The third mechanism is euthanasia. It's the possibility to access medical assistance in dying when the practitioner is the one that provides the lethal agents that will cause death. And we have a fourth mechanism that is quite new, and this is medically assisted suicide. In 2022, last year, May 2022, the Colombian Constitutional Court allowed this fourth mechanism, the medical assisted suicide. These four mechanisms, the palliative care, the refusal of treatment, euthanasia, and medically assisted suicide, encompasses the fourth mechanism that are available within the umbrella of the right to die. So the right to die here in Colombia is not a right to euthanasia. It's a right to value your own life, your own autonomy, your own suffering, and make decisions regarding the end of life and regarding death. This is why Colombia is one of the most advanced countries in the world, because all of this is legally protected and available here in Colombia. So when it comes to access medical assistance in dying, you have to fulfill three requirements so the procedure is accepted and performed legally. The first one is to have a serious and incurable illness. From 1997 to 2021, our legal system required to have a terminal illness. But in 2021, the Colombian Constitutional Court refused that requirement and opened it to a serious and incurable illness. And this had opened a lot of discussions regarding what kind of illness are serious, are incurable, because the terminal illness requirement, the late terminal illness requirement, shrinked the possibilities to access medical assistance in dying. But this serious and incurable illness requirement has opened it to HIV, any kind of neurological disease, illness, and of course, mental illnesses. So this is a huge discussion here, but this is the requirement. You have to have a diagnosed serious and incurable illness in order to access med. The second requirement, that is kind of the most important, is an unbearable suffering, and that kind of suffering can be physical or mental. What is unbearable suffering regarding within our legal system is any kind of suffering that is incompatible with one's idea of a dignified life. So this is a subjective requirement, and it is for the person to value your own life, your own autonomy, your own suffering, and decide what is compatible with your idea of a dignified life. So this is not a blueprint of suffering. It is the responsibility of every single person that requests the procedure to decide what is unbearable and what is not. And the third requirement is to have free, informed, and complete consent. And consent can be direct, in advance, or surrogate in Colombia. These three requirements are at the core of the procedure and at the core of the bioethical and legal discussion regarding this right. So how a country like Colombia came to be one of the most advanced countries when it comes to this kind of right? Well, this is a 30-year process that I will summarize for you. It all started in 1993 with a decision regarding the adequacy of therapeutic effort. So this was a case with a woman with a cancer situation that refused treatment, and her family was trying to force her to access treatment, but she refused it. So the court protected her right to refuse treatment, and in that decision, the court started creating the right to die. and it started saying that the possibility to refuse treatment or to make the adequacy of the therapeutic effort was part of a constitutional right, was part of the constitutional right to live, to die, and the protection of human dignity within the Colombian Constitution. In 1997, the same court, the Colombian Constitutional Court, decriminalized euthanasia. And this was done by declaring unconstitutional the criminal offense of mercy killing. And in doing so, the court opened the door to perform the euthanasia process legally and created the right and created the requirements. In that date, was the same requirement that I already described, but the court established that the person had to have an terminal illness. So in 2014, the court created the rules of procedures. You will be wondering what happened between 1997 and 2014. Well, the Congress did not legislate on this. The court said the Congress, please pass a law establishing all the requirement and all the legislation needed to access this right, but the Congress refused. So in 2014, the court, in one of the most important decisions, acknowledged that the lack of legislation was a barrier for the citizens and created the rules. And in 2014, the court did that and created every single rule to access euthanasia legally within the Colombian legal health system. Then from 2014 to nowadays, we have had a lot of decisions. In 2017, the court allowed euthanasia in children, in all of those who were minors, were under 18 years old, and also provide the possibility to access euthanasia doing the best interpretation of will and preference of the person. This is the surrogate consent. But legally, we prefer to use the legal principle of the best interpretation of will and preference instead of best interest or surrogate consent because of the bioethical and legal implication of this kind of term. In 2021, the court removed the terminal illness requirement, as I have said, and in 2022, May last year, the court declared unconstitutional the criminal offense of assisted suicide, and in doing so, it created this fourth mechanism. This is a very, very, very simple summary of the path that we have gone through to decriminalize euthanasia, decriminalize assisted suicide, and create the human right or the constitutional right to die. So you will be wondering how you get this kind of procedure within the medical system. And this is kind of the simplified path. So the blue part is the person and the pink part is the health system. So it's a very simple path. The person makes a personal assessment of requirement. So you wonder yourself if you fulfill these three requirements. And if you think you do, you can make the request to your doctor or to any kind of hospital or any place where health services are provided. Once you make the request can be written or verbal. The doctor or the practitioner that received the request has to report the request and has 1 day, he or she has 1 day to report the request and then activate the committee. It's one committee that has 3 persons, one doctor, one doctor, one psychiatrist, and one lawyer. And it's that committee that the one that will make the medical assessment and will assess the 3 requirements. And the committee has 10 days to reach a decision. Once the committee reaches a decision in those 10 days, the person can set the date or decide the date, and then the procedure is performed on the date and time that the person has chosen. This, in theory, will take 11 days. In practice, can take 2 weeks, 1 month, 3 months. That will depend on the discussion within the committee and the discussion regarding is there is a serious and incurable illness, the consent is complete, the suffering is unbearable, and well, it will take months if you have to go to court in order to force the decision of the committee on the, or discuss the situation in front of a judge. But in theory, you can get the procedure in 11 days. So I'm reaching the end here. Finally, I will like to share with you some quantitative overview on euthanasia, so you can have an overview of the data. So from 2015 and 2022, there have been 322 procedures. We started in 2015 with 4 procedures. That is the first year from which we have data. From the past years, we didn't have a unified register, so we don't know how many procedures have been performed. So in 2015, we had 4 procedures, and in 2022, last year, we had 99 procedures. Last year was the year with the highest number of procedures in the history. In 8 years, the procedure have multiplied by 24. Those are not big numbers because Colombia has a population of 50 million persons. Kind of in population, it resembles the state of California. So regarding our population, the mortality rate, well, 99 procedures in the last year is not a big number, but it's an important number because it shows how society get used to the discussion and start asking doctors in the consultation about their possibilities and their wishes. So we look this data with a lot of care and try to make the best of it. For example, in the last year, we had kind of 336 cases in which the committees have been activated. So those are requests, people that request the procedure. And in most of the cases, 96% of the cases, the committee is activated. That doesn't mean that the procedure is approved, but the committee is activated and the people that requested it gets an answer or either positive or negative. In a very few cases, the committee is not activated. There is some kind of balance between men and women. There is not a gender or a sex gap when it comes to euthanasia procedure, and is well distributed. In some years, many women or more women have access to euthanasia than men, and in other years, more men have access to euthanasia than women. But in the overall data, we have a relative balance. When it comes to the country, we can see the gaps. So the distribution of the procedure, that is the first graphic you see on your left, you can see that the procedures are concentrated in the most developed and rich parts of the country. And 80% of the procedures are performed in 2 cities, Medellin and Bogota. And this is important because Bogota has 9 million population. Medellin has a 5 million population. But in the second city, that is Medellin, there are more cases than in Bogota. And the procedures are not spread or evenly spread around the country. There are a lot of departments, that kind of states, where no requests are made and where no procedures of euthanasia are performed. So you can see a geographical gap when it comes to the data. Then, when it comes to the kind of illness or the illness distribution of the procedure, we can also see a situation here when the cancer-related procedures or the oncological situations that so people had cancer, and in most of the cases, in 80% of the cases of euthanasia, the person has an oncological situation or a cancer-related illness. And this is because from 1997 to 2021, you have to have this terminal illness requirement, and that requirement benefited cancer situations because it was easier to establish when a person had a terminal illness when it was a cancer-related situation. But in the last year, we have seen that non-oncological cases have been growing. And for example, neurological conditions like ALS or Parkinson or heart failure, those kind of cases have been increasing in the past years or in the recent years. But the gap is still there. A lot of people with cancer access euthanasia, and less people with non-cancer illness or cancer-related situation, less people access to euthanasia. And the last slide here, and the last idea that I wanted to share with you, is the use of advance directive. And the use of advance directive is very low. Only 25% of the cases of euthanasia counted or had an advance directive, and 75% of the cases have happened without an advance directive. And this is one of the most complicated situations that we face, is that there are a lot of legal mechanisms available, but people do not use advanced directive. And this is because these kind of conversations have no place within the medical consultation. So we have to put a lot of effort on that and change this kind of situation. So with that, I will finish my presentation of the overview of the Colombian experience regarding this right.
Fantastic. Thank you so much, Lucas. And we are all back on the stage, so welcome back. So let's begin our conversation. So Lucas, I have so many questions to follow up with your presentation, but I want to pivot back to a place where Jane left us, and to kind of ground us in, for a person who may be located physically in the United States or a country where, expanded access to assisted dying is not legal. How ought we conceive of a person planning the time and circumstances of their own death from a societal and philosophical perspective? So Jane, what are your thoughts?
It depends. I think it's really interesting if you look at the United States versus Colombia versus the Netherlands or Belgium, how there are different norms about individual rights. There are different roles of the church or other churches in those societies. They may be secular or religious to varying degrees. So there are different sets of considerations about what an ethical standard looks like, and it's not always the same everywhere. We're really good at thinking about just our own context and what we want as individuals, because we're Americans. We want our own set of choices. But not every culture has reached this point in the same way. I think there's it's a series of very difficult not decisions, but discussions. What is right for the individual? What is right for them, possibly within the context of their family? What is right for the patient, their family, within the context of their community? And then what has the government decided is beneficial or allowable? And so there are these pathways where somebody can choose a very legal, very prescripted route. We must have a life-limiting illness or a serious illness, et cetera. There are other people who will never fit those criteria where they live, and they have a completely different set of social prescriptions that they have to consider in weighing their options. And folks who choose VSED, for example, often fall into that situation because it's a little bit outside the law.
And how do the tools in our, expanding palliative care and ending life toolbox advance or perhaps slow down the process of planning, a completion of life?
There's a lot that good palliative care can do, which I think the Supreme Court of Colombia is acknowledging. There isn't necessarily equal and equitable access to those services. Palliative care is in short supply. It's more readily available in large urban centers, in rural communities. Clinicians may not have the training or the resources to provide that level of specialty care. So what's possible theoretically, medically, is one thing. What is equitably available is another question.
And Lucas, to tie in, your perspective from Colombia, especially in a predominantly Catholic country, how would you say that clinicians and lawyers and bioethicists and other patient advocates address this complex issue?
Well, this is kind of a very complicated situation here, but I have a personal opinion regarding this. So on the one side, you will find the regular person that is, many of them are Catholics, and they live what I like to call like a free and practical approach to faith. So they do believe, but they also want to make any kind of decision regarding the end of life. So they are practical believers. This is the word that I like to use. So we had a lot of different women and men that are believers, and they find the access to medical assistance in dying completely compatible with their faith. So, and this is very different what the Catholic Church tells them, but this is what they feel. And I would like to use the words of Marta Sepúlveda, that was the woman that accessed euthanasia, and she was a very Catholic woman, and said God was a caring father, and no caring father wants their children to suffer. So this is kind of the situation here. Of course, you can find religious person that will not access euthanasia, and that is completely right. And that is the main possibility regarding the right to die, is that nobody is obliged or is not mandatory to access medical assistance in dying. What is the right is to decide, and you decide what is good for you, what you believe is compatible with your idea of dignified life or existence. But on the other hand, in the Colombian context, the palliative, many of the practitioners of palliative care, those doctors and nurses, are highly influenced by the Catholic Church, and they are educated in Catholic universities. And this creates this kind of tensions when you have a patient that asks for their information regarding their possibilities in the end of life, and the doctor says, I can't tell you this. This is incompatible with what I do, and this is something that we are trying to change, but it's very, very difficult because the institution where these kind of doctors are educated, well, are controlled by the Catholic Church. So this is what I like to call the believer's gap. In the base, you have a lot of people that believe in God, but find the right to die completely compatible. And at the top of the mountain, you can find the Catholic Church and tell them this is not acceptable, but many of them do not listen to them. In the last poll, national poll, recently a question regarding euthanasia was introduced, and the approval of euthanasia was above 72%. 72%. The approval of abortion is below 32%. So this is kind of the situation regarding the beliefs and the spirituality of Colombia, or at least my opinion on that.
Oh, thanks very much. That's very insightful and enlightening. So I want to probe a little bit on this idea of what makes the process of, crafting and taking charge of your end of life experience as the so-called good experience, right? A good death per our event title today. What parts of it are good? Is the value judgment of good the best way to describe it? And how does that interchange or interweave with personal autonomy?
I think one of the things that distinguishes the motivations of people that pursue assisted dying or VSED from the literature, from suicide, which is part of the bigger sort of linguistic background to today's conversation, is what's the intentionality? And generally speaking, people who are choosing to pursue or interested in assisted dying are, all things being equal, very much would like to be alive, but what they are living with or what they are afraid will be coming as their diagnosis progresses is something beyond what they feel they can bear, but they expect to have to live through it. And that intentionality, I think, is important. There's the idea of the death itself being good, the actual experience of the dying act, but there's also, I think, an implied meaning of the greater good is that the death serves a bigger good purpose, which is the cessation or avoidance of suffering. In the sense of, thinking about who's administering the lethal agent, is it being ingested orally or is it being administered by a physician intravenously or whatever? There's a much narrower focus on like what is good in that. Is it painless? Is it easy? Is it reliable? Is it safe? Is it effective? Is it without complication? So it could be those things as well, but I think it depends on who's asking the question.
Thank you. This idea of, choosing the timing and circumstances of your own death is certainly a radical notion to us here in the States. And yet, if you have an irremediably challenging physical condition, whether it's a quote unquote terminal illness or something that is unbearable. You know, that context has already chosen, in some sense, your timeline to, you know, a point on the horizon. And so, Lucas, I'm curious from your perspective, how do Colombians perceive this kind of boots on the ground style of from the ground up of a personal and social construct?
I guess this kind of discussion and conversation was very important in 2021. That was the year when the court eliminated the terminal illness criteria or requirement. And the discussion had place on the media because we had two cases, two women, Yolanda and Martha, and these two women had ALS, a neurological condition that was life-limiting, but was not a terminal illness. And all the discussion revolved around the obligation to live. I don't have an obligation to live, and I have a right to make decision regarding the end of my life. And in that year, we had two women, one 70-year-old woman, and Martha was a 50-year-old. So one was a grandmother, the other was a mother, and all the discussion revolved around they wanted to die, they wanted a dignified death, and they considered that their life was completed. And the discussion was, do they have to wait until the illness evolved from this stage to a terminal stage, or they can decide right now? And the court say they can decide right now. They can decide whenever they want, because it is for them, in this case, Yolanda and Martha, to value what is a dignified life for them. And if that life is not dignified for them, they can access euthanasia. And that was what happened. They accessed euthanasia. They didn't have a terminal condition, and that opened the door to this kind of discussions and these changes. And it's kind of the main challenge we face is that once you don't have to have a terminal illness, you can have this conversation whenever you want, and that means that you are in control of your life and in control of your existence. Of course, this is not neutral, and we have a lot of situation regarding depression and mental illness when this discussion is quite more difficult. But you can have this kind of discussion regarding early stages of cancer, failure, kidney failure, heart failure, any kind of neurological illness. And this, I like to use the expression, we have to have this conversation on the diner table, on the dining table with our family and with our doctors, and not on the ER or on the intensive care unit, because on these places it might be too late. And this is why you have to take control of the end of life decision and ask your doctor your options, the treatments that are available. And this is kind of the main challenge. I will not like to extend on this, but the doors are open, and every single day, any kind of Colombian with different situation regarding HIV, for example, any kind of neurological condition, are requesting this kind of procedure. Not in a mass. This is not not a lot of people, but they do it, and they do it because they watch it on the news. And this is the main transformation that we are facing here.
Thank you. So a question for Jane, and then a couple more questions for Lucas, and then we'll turn to our audience questions because they're coming in fast and furious. Um, so, so Jane, it seems like, for states who don't have necessarily a progressive assisted dying laws, medical aid in dying in the United States is limited to, I believe, 10 states, and also the District of Columbia. And to Lucas's point of, by the point that someone gets to the emergency room or the hospital and they're discussing their end of life wishes, at that point it's too late. Often this idea of what may be, quote unquote, a good end of life experience is highlighted in the context of contrast with what might be a bad experience. And the notion of extreme measures vividly evokes medical interventions at the point of excess and possibly creating harm in the process. For example, chest compressions and resuscitation on a frail 98-year-old who may have a do not resuscitate order, which perhaps was left at home in the chaotic frenzy of calling, an ambulance and EMTs. So from that cultural perspective, we certainly in our timeline in the States are at this point of, withdrawing or withholding life-sustaining treatment or life-sustaining nutrition and hydration to the point of VSED. That is our moment right now with, varying legalities towards medical aid in dying, but patient must self-administer. So Jane, where do we go from here? How do we shift the conversation in the right direction of empowering folks to, step out of that paradigm of waiting to the very last minute?
There are several decades of medical research that suggests that it's very difficult. There are a lot of studies about how to get people to complete advance directives, how to get those into the medical chart, how to get them enacted in the time where they matter, that have really mixed at best results. And I think there's a lot of reasons. Some are individual, some are cultural, some are technological. I will say, as a social scientist who sits in a school of medicine, I think one of the core issues is things like advance directives tend to be focused on very medical aspects of what might happen at the end of life. They're focused on ventilation, antibiotics, CPR, things that really would make or break the situation in an emergency room, like you mentioned. But living with frailty, living with complex illness and so forth is so much bigger and more nuanced than that. What quality of life looks like, how you're living day to day, what your kind of social and relational life is like. There's a whole lot that actually is really important. And a lot of times now when we talk about what people can do to plan for the future, we talk about having those conversations at a broader level with the people in your life so that they understand the full context of what you consider to be a good life, a high quality life. And those things can be a lot more useful than an individual decision about CPR that may or may not actually be the issue. CPR might not be what you need. You might need some other life-sustaining intervention that wasn't on the form. So having a broader conversation about what is important to you with the people who will make those decisions, having people designated who will make those decisions, those are all really important and also really hard to do. A lot of people just don't want to talk about this. they would prefer to avoid it at all cost and hope sincerely that they will die quietly in their sleep without too much warning. But I have to say, like, a lot of this discussion puts the onus on the individual, and we are all swimming upstream in a healthcare system that isn't built for this. It isn't built for long-term chronic illness. It isn't built for an aging society. We need to fundamentally rethink as a culture how we value frailty, how we value diminished capacity in various senses, because those are the things that are driving a lot of this. People can only do so much as individuals. We need policy reforms that support better quality of life for things like dementia so that people aren't as afraid of it. They don't need to fear that outcome quite as much as they do now.
Thank you. So one more question to Lucas, and then we'll jump to audience questions. So you've mentioned a few times the qualifications for a patient to apply for euthanasia in Colombia, and I was wondering if you could, while briefly walking us through the process of someone applying. You mentioned in your presentation a larger number of cancer patients typically apply for euthanasia. And I'm wondering, one, what are the qualifications for euthanasia to be provided to the patient? And then as a follow-up question, what cases are typically approved and what cases may be denied?
Okay, well, cancer-related conditions are the cases that are typically approved because all of the narratives that are around cancer. And other conditions, for example, like neurological conditions like ALS, are highly approved in the past years because of the place that the place in the media and the place that that kind of illness has in the social ideas. But other cases, for example, heart failure, kidney failure, mental illness are highly like refused or denied. And this is because of the first criteria to have a serious and incurable disease and the medical discussion regarding this. And for example, I will tell you about a recent case, and this is a person with glaucoma, and he has lost sight on one eye, and the other one is working 50% of the side. And he says, I want to access medical assistance in dying. I don't want to be blind. I want to be autonomous. I want to drive my car. I want to live by myself. And this is the life I value, and this is what I consider a dignified life or a dignified existence. I don't want to I can access care, and I have the economical situation and family situation when care can be provided with no difficulties, but I don't want that. I have the right to be care, but I don't have an obligation to receive care. And I want to be independent. And this is a 55-year-old person, and he requests euthanasia. And this is a case that is most likely to be denied because glaucoma is a serious condition, it's an incurable condition, and the bioethical discussion and the legal discussion here is this kind of illness that is serious and incurable renders or gives you access to medical assistance in dying. I believe it does, because it's for the person to decide, and this is what the court has said. It is for the person to decide. What is at the center here, at the core here, is the idea of a dignified life. You have a right to live, but you have a right to live a dignified life, a life that is fulfilling to you, to your ideas, to your purposes, to what you want, to what you wish, what makes you happy. And of course, there is a tension here because this is a lot of value is placed here on autonomy, on health, on avoid suffering, avoid blindness. This is avoiding disability, but this is the real case. And these are the cases that are at the forefront of the discussion, and are the cases that are mainly denied. Now, that will depend where you are located in Colombia. So cases of cancer can be denied or refused, and it depends on the committee and those who sit in the committee. But this is kind of the process. You request the procedure to your doctor. I'm in this medical consultation, and I tell the doctor I want to access euthanasia, and the doctor tells you, yes, I will register the request and activate the committee, and then the committee is activated, and the committee is the one that will assess the situation and will decide. And then you get your answer. It might be positive or negative, and after that you will see your legal options. If the procedure is denied and you feel or you think that your right has been violated, you can go to court, and with a very short judicial action that is resolved in 10 days, you can get a court decision regarding this issue. If the procedure is accepted, then you set a date, and that's it. For example, one positive case is a case of a cancer. I have a person that we accompany through this path, and she had cancer, and is at the final stage, and she does the request, and the request is approved in less than 10 days, and she sets a day 2 weeks in advance, and that is scheduled on Monday the 11th. And it's as simple as that. The procedure takes less than 10 minutes, and everything is set, and the procedure then is performed.
Thank you. You mentioned that the criteria for euthanasia must be that it is safe, protected, and accompanied. And I'd like you to define what that means in this context in a moment. And also, who you mentioned a approval committee who decides who gets approved and denied. Who sits on that committee?
Okay. So last year, when we had the case regarding assisted suicide, we find these 3 words that describe what a dignified death is. Because a lot of people said, if you can access medically assisted suicide, or if you can access euthanasia, what are you looking for? And the answer is that I'm looking for a safe, protected, and accompanied death. Because I can kill myself, but I don't know how to do it. And I don't know how to do it in a safe, protected, and accompanied death for the person and for the family. And this is the discussion that is behind the medically assisted suicide, because a lot of people in this country commit suicide. I can tell you the data. 99% access euthanasia. More than 3,000 committed suicide last year. And those who committed suicide, we don't have that certainty, but made or might prefer to access a safe, protected, and accompanied death. And this is what is behind this right, is to access a medical practitioner that is educated, that has the knowledge, the means, the setting where the death can happen in these 3 words: in a safe situation, protected, and accompanied for the person and for the people. And this is what we are looking for, and this is what a dignified death means to us. And the committee, for the second question, the committee, well, three kind of persons sit in the committee. The one is a medical specialist. If it's a cancer-related request, then it would be an oncologist. If it's ALS request, it would be a neurologist, and so on and so forth. The second one is a psychiatrist that will assess the consent. And the third one is a lawyer that will assess the legality of the procedure, because the procedure is registered and it will avoid any kind of criminal prosecution and all those kind of situations. And these three persons reach a decision, and that's it. Another doctor will perform the procedure. No, the doctor of the person that received the request will sit on the committee or in the committee, and the doctor that will perform the procedure doesn't sit in the committee. I don't know if I'm clear with that. It's like a third part body that will assess the case and will decide upon the case, and that's it. And those committees are located within the hospitals, or it's not, for example, the Spanish arrangement or the Portuguese arrangement, the Spanish arrangement, I think they have these regional committees. But those regional committees are located within the state or within the city, and they are separated from the hospitals. In the Colombian case, these committees are located within the hospitals, and those who sit in the committee work for the hospital. Even the lawyer works for the hospital, and that's kind of the situation of the committee.
Well, thank you very much. That's very enlightening in terms of the rigors of the Colombian Committee safeguards. And I think it helps dispel a lot of myths surrounding euthanasia, and that level of specificity provides great insight. And I really appreciate the distinction that the criteria must be safe, protected, and accompanied in order to ensure the dignity at the very end. So thank you for going into those details for us. Joanna wants to know if your request gets denied, is there an appeal process and perhaps a way to reapply further down the line?
That question is for me, right? So you have a lot of options. You have the possibility, you cannot appeal to the same committee, but you can have a second committee composed with three different persons. So this is a second option. And this is one option. And a third option is to go to court. So if the committee said you don't have a serious or incurable disease, you go to court and say, I do have a serious and incurable disease, and the judge will decide. And this is a very complicated situation, because you get a judge that is a lawyer to decide what is and what is not a serious and incurable disease. And many of the judges, what they do is not to decide whether or not the situation is serious and incurable, but order the committee to assess what the people is saying, and then order a second committee, because the judges feel that they tend to feel, and this is understandable, in a very weird and complicated situation, because it is not for a judge or for a lawyer to decide. And this is why many of the cases do not go to court, because it is not a good place to have this kind of discussion, but is the last resort. So you have this second committee, and you have the possibility to go to court. And you can always reapply. So in many of the cases, you have 1 or 3 requests, and then you reapply 6 months or a year later, and you get to a different result. Even you reapply in a different hospital, for example. The first request is made in one hospital, and then 6 months later, you go to a different one and get different practitioners. And in some cases, you get different answers.
So thank you. Sarah is wondering what happens in Colombia when the family of a person who requests death is in disagreement. Does the committee go against the family in favor of the requester? Presumably the requester is the patient.
Yes, well, the family has not saying in this. It is for the person to decide, even if the family or the support network is against the decision. However, in reality, these kind of decisions are likely to be made alone, and many of the cases that we have accompanied, we have like assist, this is kind of a family decision, and at the end are the partners, even the father or the mother, or even the children, that look for help, look for the lawyers, look for the doctors, look for the information, and provide information to their families. Of course, there are cases when some family members are in disagreement, and a lot of things happen in those cases. For example, when the patient or the requester knows that, for example, one brother or one kid is not going to be in favor of this, they start the procedure without telling them. And at the end, when the procedure is approved, they tell all the family. However, this is complicated when the person is not in full capacity and is the family that is the one that is making the request, even with an advance directive or using the surrogate consent. And here it becomes a problem, because you can have one children that is in favor, one daughter that is in against it, and the committee is the one what will decide this kind of conflict. And what happens in reality is that if, for example, we are the committee, we will sit with the daughter and we will ask her, why are you against this? And at the end, with a deep and loving conversation, you, in many cases, you will find that it's not that the person is against it, but she or he feels sad, lonely, or hasn't had the possibility to talk to someone. And when there is this protected environment, this kind of situation resolved. But of course it can happen, but at the core of the decision is the person, the patient, or the directive that was taken in advance.
Thank you. So Jane, I think this question is directed mostly at you, but Lucas, feel free to chime in if you have a few thoughts. This is from Tim Quill, Dr. Tim Quill of Quill v. Vaco. Hi, Tim, if you're still in the audience. He's wondering, would people denied access to MAID be allowed to stop eating and drinking, which would be totally under their control?
I don't know. I feel like that might be a Colombia question. I know, for example, that the Netherlands has guidance specifically for clinicians on how to address people who have been denied a request for assisted dying, who then choose to pursue VSED because whatever their medical reasoning wasn't approved. So how would that fly in Colombia?
I'm not really sure.
Is VSED a standard recognized practice, or is that something that, we talk a lot about in the States?
Besides voluntary,
stopping eating and drinking.
yeah, it is, and within the palliative care provisions, um, in many cases this is acceptable, and it happens. What is a problem is when you can do it. Look, I cannot use the technical terms, but once you have, like, when they are feeding you through something, once this is installed in you, it cannot be withdrawn without an advance directive or with full consent of the family, and those are very, very complicated situation, because doctors do not call that medical assistance in dying. I do believe it's kind of medical assistance in dying, because you know that the person will die. But these kind of situations happened and are complicated once this life support treatment is installed or is in place.
Certainly very interesting. Thank you. Jane, did you happen to have any question as follow-up to that, or did that answer your question as well?
No, that's, I think, not making it more difficult to withdraw life-sustaining measures is a really interesting spin on the situation.
Indeed. So last question from our audience, and thank you all so much for sending such thought-provoking questions. We really appreciate it. This one is from John. He said, 1/3 of assisted deaths at Life Circle in Switzerland are in the category of old age rational dying. That is, quote unquote, I have lived a completed life. Is this being considered in the US or in Colombia?
I don't believe it's considered for aid in dying in the United States, because we specifically legally have gone the direction of you must have a life-limiting illness, you must have 6 months or less expected to live. I'll say, for my own research, looking at people who elected to stop eating and drinking to hasten death, either because they didn't qualify for medical aid in dying, or it wasn't available, or they didn't qualify, or it didn't occur to them to pursue it. In my research, the cases were about 1/3 life-limiting illness, the sort of people who would have qualified for MAID if it were available. About a third were people who had an early diagnosis of dementia and wanted to get out ahead of it while they still had capacity. And then another third were people who essentially were done with living, had a completed life. And from talking to Tim Quill, I know that it has looked similar in his clinical practice as well. So it happens. It's happening a lot, but that's not the legal context for getting a physician involved at this point.
Thank you.
In our case, I think this is the next step for us. The whole idea of the right to die in Colombia has been built around the kind of illness you have and the kind of life or suffering you evaluate or you consider incompatible with one's idea of a dignified life. And what we will think will happen in the future, and we will make it happen, legally talking, is to bring cases of a completed life before the court in order to drop the medical condition criteria, because I can be a healthy person in my old age. Of course, I will have something regarding my health condition, but not a limiting condition or a serious or incurable disease. I think this will be the next step, and we are there to making it happen. However, in Colombia, the average age of people that access medical assisted in dying is 65. So they are kind of young. They are not in the end of life. We are a old country. We are one of the most, like, we are an aging society, so our life expectancy is 77. So 65, like, as an average age, is not an advanced age.
Very interesting. Thank you. I wanted to give a shout out to Judy Fine Edelstein in the chat for a comment, and I'll read it because she's quite eloquent in her writing. She says, I have been a neurologist for 30 years and am now studying bioethics. I was diagnosed with leukemia at the onset of the pandemic, relapsed after a year of chemotherapy, and had a stem cell transplant in October 2021. I have cared for patients with degenerative neurological disorders, and I thought I understood these issues, but only after being diagnosed with a life-threatening illness myself, I now fully empathize with the fears my patients have had. These conversations are essential. Thank you for this presentation. Thank you, Judy, for writing in the chat as well. We really appreciate you being here, and please take care. All right. Well, unfortunately, we are out of time, and I want to give a hearty round of applause to our incredible panelists today, Jane Lowers and Lucas Correa Montoya. And thank you all of you in the audience for sending such interesting and thought-provoking questions. Thank you for joining today's town hall event. If you want to continue to engage with the Completed Life Initiative, we encourage you to visit our website, www.completedlife.org, to learn more and sign up for our email list. We send twice monthly email blasts giving an overview of what's coming up in our programming. So if you're not already on the list, be sure to sign up. You can also follow us on social media and find more of our video content on YouTube, all of which is listed on your screen. And thank you to our technical team working on the back end behind the invisible curtain for their efforts to make today's event run so smoothly. And that concludes today's town hall. Thank you all so much. Take care and see you next time.